what I do for work is I work with patients, oftentimes work with medication tapering, and some really sensitive conversations. And over my years of doing this, I have found out a lot of things not to do. My job, I really learned a lot of this just baptism by fire. So this talk doesn't have a lot of research in it. It just is my observations and the world according to Eva. We'll go to the next slide. And the next slide, that's just me and contact information if you guys need it. So we'll get right into it. I have an always column and a never column when you're having difficult conversations with patients about anything. And so I really think this first thing is important, centering around the patient and never center around anyone else, because many patients, if they have any kind of complaint, they're saying, oh, I wasn't listened to, or I'm being treated like a number, or not treated. I'm getting treated, put in a box with other people, and that sort of thing. And people never want to feel that way. So you really want to center the conversation around the patient, and not around a law, not around anything other than that. You want to take responsibility. I have found that when I mess up, the best thing to do is say, hey, I messed up, but here's what we can do to fix this. And never blame anyone else. And so that's touchy when there is somebody else who maybe made a mistake. You never want to give the blame anywhere else, and take the responsibility that does belong to you. But, you know, of course, don't take extra responsibility either. So you have to be clever with that. But always be kind and patient, which can be hard to do when these conversations get emotional. But you don't want to let your own emotions take over the appointment. Be direct and honest, and never dance around the topic. I've had folks come to me after having a very important conversation with their provider and not even understand the what happened in the appointment, because things were so indirect and not giving them exactly what was going to happen. Next slide, please. And so discussing medications, this is what I have done a lot in my career. And some things to remember as the provider and the person having a conversation about medications is that your patient did not prescribe these medications to themselves. So even if the patient is coming to you on medications that you feel really should be changed, the patient usually it wasn't their idea to begin with. They're just following medical advice for the most part. And somebody told them that they need these medications, and maybe you told them this, and medicine changes, and sometimes you have to change the plan. But people are very fearful of change, and that fear does tend to put a magnifying glass on whatever symptoms you're talking about: anxiety, depression, pain. All those things seem to get magnified when somebody is in that fight or flight place. Next slide. So how do you break the news? You've been looking at a chart, or you've been doing some prescribing that feels yucky, and so you've made a decision that you have to make some changes. Before you talk to the patient, know your rationale and be confident in that. So you want to do your homework and make sure that you're not making changes because somebody else made changes for another patient. You really want to make sure that you know why these changes make sense for your patient. Meet your patient face to face. I absolutely hate it when providers, or I don't hate it, I guess, but I don't think it's good form when a provider will send a letter to a patient saying, hey, you know that medicine you've been on for 50 years, I'm going to change that. And I think that's more a provider preference, that, hey, it would be easy to write a letter and just tell them what we're going to do rather than sit in front of them and hash it out for 45 minutes. You want to have a plan figured out, but be flexible with your plan. Sometimes after you talk to the patient, you figure out, well, you know, they've got a good point, and maybe we should meet somewhere in the middle where it's a compromise. But the more you do this sort of thing, the better you're going to get. So next slide. And the conversation. So this, again, is frame your conversation around the patient, their safety, their well-being. I say to my patients all the time that in order to do right by you as a human being, you deserve a chance to make this change. It's hard for them to hear it, but it's really the spirit of the conversation. Is it's about you, it's about your safety, and these are the reasons why. You don't want to frame the conversation around, you know, boy, I'm not comfortable with this or that. Although sometimes I do tell them that, you know, every time I write that prescription, I know it's not safe. I know it's not the best care for you, and I feel really yucky about it. But I don't say to somebody, I'm just not comfortable doing that, or I could lose my license, and da, da, da. They don't care about company policy. They don't care about things that don't directly relate to them and their condition. Nor really should they. And I reassure them. I use this all the time. I'll walk beside you. I tell them I can't carry them. I'll walk with you. And I'll work with you and your treatment team to treat your symptoms in other ways. And acknowledge that medication changes are difficult. Nobody thinks that this is easy, and your patient doesn't either. And normalize anticipated discomforts that can happen. I take people off opioids all the time, and sometimes people can get refractory pain. It's temporary, it will get better. Another good one is when you try to taper somebody off Ambien, oftentimes they might not sleep for a couple of nights because they have a lower dose of Ambien. And I tell them, let's expect that. You might not sleep for a couple nights, so let's make this change on nights that are good for you, that you don't have to be Johnny on the spot the next day, that it's okay for you to be tired for a couple of days. Next. And so this is kind of fun. I have a cast of characters here of kind of different patient persona, not meant to be making fun of anything, but I think a lot of people will see this in their own patient population, these cast of characters. Next slide. The first one is the negotiator, the person to find every reason not to make any changes. Again, they're fearful. A lot of people will tell you they don't care about their safety. They don't care if I die. Some will threaten to take up alcohol, other illegal drugs. You know, this feels like a disaster to them, and so they're going to negotiate with you to try to not make changes. Sometimes you see threats of suicide. I call that non-reassuring behavior. And my you know, what I usually say is I care about you and want to offer you the best care. And things like suicidal thoughts are not treated with this drug, but if you're having suicidal thoughts, we can address this. Next slide. The next character is the sad face. They really are feeling betrayed or punished, and they could cry and not believe, and they also will think you don't understand how bad they feel. And again, I care about you is what I usually will start with, and I want to help find a sustainable way to treat whatever I'm trying to treat. Next slide. The angry bird, again, this is similar to the sadness, but a lot of people get really angry with medication changes. You might not agree within that appointment, and don't take their anger personally. Remind them why you're making that decision and why it's important, and just be careful of their behavior. Sometimes when people seem a little aggressive or abusive, just offering them alternative behaviors has been helpful. Reassure them, I'm not leaving you, I'm not firing you, we will talk again. And I always have a promise when a patient gets angry that it's okay you're angry. If you need to leave the appointment, I will not chase you, we can reschedule. Next slide. Eager beavers, some people are really excited about making medication changes, but if they go faster with certain tapers, they're going to sabotage themselves. So caution them to really stick with a plan even when it feels tedious. But these folks can be fun to work with, although a couple of folks have been in benzodiazepine withdrawal in my office, and that's a remarkable thing to see when it's really full-blown. Both of those ladies did stick with their tapers after we had a chat. Next slide. The inheritance, this is last but not least. Consider that they might have some abandonment issues or hero, whoops, there goes my timer. Hero worship, good thing this is the last slide. Hero worship for the previous provider. Do not just continue with someone else's plan as a matter of routine. You all have your own brains and should use them and give your patient the best treatment plan you know how, and let them know that you'll be different and you plan to help them through medication changes. And I like to tell them, I think your previous provider was awesome. We just do things differently, and I'm sure that everyone has had the desire to help you, and medicine changes.